I'm going to try to share with you a little bit on in the non-invasive space and how to apply some of the learnings that we have from your collective work and the work of others, but also the work from CTA. Any of you who have been subjected to hearing me talk before would say that I should also disclose that I'm a CT zealot. I'm very zealous about the role of coronary CT angiography, but I think I am zealous because the evidence supports my opinion. And we saw that for the first time, a multinational society, the European Society of Cardiology, came forward with the first class 1 indication for the role of CTA in so-called chronic coronary syndromes or stable angina. In this case, we can see class 1B. And in fact, the guidance from the ESC was to consider CTA for the large majority of patients, except those at extremely high pretest likelihood for coronary disease. Why did they come with this guidance? Well, I think they came with this guidance because CTA helps answer all of the important questions that are being asked up front in patients with suspected but not yet confirmed coronary disease. We've known for some time that it is the best non-invasive tool for the identification of anatomical coronary disease. It safely excludes disease and reasonably confidently, on a per-patient basis, confirms the presence of anatomical stenosis, and in fact uniquely identifies non-obstructive or non-stenotic anatomical atherosclerosis, unlike any other non-invasive test. We've also known that it has helped answer this very important question for the patient and the clinician, in that we know that coronary CT is highly prognostic. The virtual ACC, we saw David Marin present very important data that showed for the first time, in a fashion similar to anatomy provided by invasive angiography, that the anatomy is highly valuable with regards to predicting risk of downstream mortality in a fashion that the extent and severity of stress testing abnormality does not. And what we can see here is if we look at the trend, patients with severely abnormal stress tests had actually a lower mortality rate than those with no or mildly abnormal stress tests. On the other hand, when we looked at the CT anatomy, the likelihood of mortality was significantly higher with those with 3-vessel stenotic disease or proximal 2-vessel disease as compared to those with 1-vessel disease. And finally, we've learned from many of our friends and colleagues in the UK that CT helps guide medical management and decisions around atherosclerosis management that afford an opportunity for reduction in downstream myocardial infarction. This is the 5-year Scott Hart data. So while I'm zealous about CT's opportunities in providing a lot of information with regards to the upfront diagnosis and understanding prognosis, and even helping guide lipid management and medical therapy around risk reduction, what we've known for some time is that CT alone has not been able to answer this final question. Should I stent this LAD lesion? Should I stent the circumflex lesion? And so on. And this is work from the Veteran Affairs database published by Bill Fearon and Dr. Parikh as the lead author. And what you can see here is that when you compare FFR-guided revascularization as compared to angiographic-guided revascularization, those that were revascularized on the basis of physiology, lesion-specific invasive physiology, experienced a 43% reduction in all-cause mortality as compared to those who were revascularized on the basis of angiography alone. Guiding revascularization not on the basis of the severity of the stress test abnormality, as we saw in the ischemia trial, and not based on anatomy from CT or invasive angiography, but rather invasive physiology or a measure of physiology is what's really needed. We've heard why anatomy and physiology are not the same. And we know that it's not the same with invasive anatomy. Well, there's no reason to obviously think that it's going to be more consistent with non-invasive anatomy. This is work that was put together by Tim Fairbairn from the Liverpool Heart and Chest Hospital, looking at the advanced registry, over 5,000 patients who had undergone CT and non-invasive FFR-CT evaluation. And what you can see is across the LAD, circumflex, and RCA, blue is a positive FFR-CT as defined by binary cut point, red is negative FFR-CT, so no lesion-specific physiological abnormality. And what you can see here is that there's significant discordance when we look at an anatomical cut point of 50% in about 36% of patients, and that holds true across all coronary territories. So what often people ask me is, is physiology then only needed for moderate anatomical lesions? And what we started to look at within the advanced registry is what incremental information does FFRCT provide you in the setting of a 70 to 90% stenosis? We know from Ripcord, we know from FAME that roughly 20 to 25% of anatomically 70 to 90% lesions by invasive angiography are negative physiologically. Well, we found something very similar in the advanced registry. 1 in 4, in fact, did not exhibit findings of physiological significance. Patients that, in fact, have been shown now consistently to be able to be safely deferred from revascularization. In addition, what I found very interesting was that amongst those with CAD-RADS 4 lesions, 70 to 90% lesions, a large majority of those lesions, 60% of the total, and in fact, closer to 75% of the positive lesions were profoundly abnormal. And I think this profound abnormality is quite helpful because we know from the work shared earlier and then more broadly, this from Niels Johnson, published in 2014, is that in a randomized trial, physiology is, of course, used in a dichotomous fashion because you have to randomize across a binary cut point. But in clinical practice, an FFR of 0.57 is much more significant than an FFR of 0.79. And in fact, as we've seen from Niels Johnson and others, that the benefit of revascularization is in fact also more profound in those with severe physiology disturbance as compared to those with only mild. We've also learned from Manesh Patel from the 1-year advanced data, as well as Abdul Idahid from the Monash and Brian Coe that have looked at the 5-year outcomes of NXT, is that the more severe the physiological abnormality with FFRCT, the higher the risk, and also almost certainly the greater the likelihood of benefit in revascularization. It's pretty rare that I highlight the limitations of CTA, but even myself, who, I'm a strong advocate for CTA, what we know is that the reproducibility of CAD-RADS scoring and the correlation of the anatomical severity of stenosis on a per lesion or per segment basis with ICA is much, much more modest. When we look at Scott Hart, what we can see is that the agreement across readers for the presence or absence of anatomical stenosis was very high. The intra-observer agreement was 0.80. The agreement between readers was 0.72, really quite good inter-observer reproducibility. But what if one reader called it a 50 to 70% lesion? Is that simply gospel? Will the next reader agree that it's 50 to 70%? For that matter, what if that reader comes back in 2 weeks and reads that study? Are we guaranteed that she or he will read it as a 50 to 70% lesion? Well, it seems that their data would suggest not. A kappa of 0.52 and a kappa of 0.46. This is data from John Mancini and our lab, as well as a collaboration with Matt Budoff and Jim Min and others. These are data from the ISCHEMIA trial looking at our core lab work. What you can see, and I'm very proud of, is that CT was a very helpful tool anatomically to confirm the presence of disease and to rule out left main disease. When we called a stenosis and no left main disease, the cath agreed with us 93% of the time. There were 5%, though, where they didn't call. They felt there was not a stenosis of greater than 50, and there were some left main lesions where there was some differences in opinion. But importantly, how about when we call a greater than 70% lesion? Suddenly, the rate of no CAD by cath of greater than 70% jumps to 10%, meaning that those stenoses that we thought were severe may not have been that severe. My take-home points, I think, from this talk is that CTA is unequivocally, in my opinion, excellent at identifying and excluding anatomical disease on a per-subject basis. What we know is that even if we had exceptional anatomy, anatomy alone is not enough to determine the physiological significance of the disease, and it's in fact the physiology that's needed to guide decisions around medical therapy and revascularization. But what we also know is that we do not have perfect anatomy from CT. You're hearing this from me criticizing CT, that segmental stenosis severity agreement between readers and with ICA is much more modest than per patient evaluation. And we know that CT anatomical findings display an inconsistent relationship with physiology. And I think also it's important that we all recognize that physiology needs to be integrated not solely in a binary fashion, but also as a continuous variable. Be well all, stay safe. Until next time.